the last very short presentation. Basically, the idea of this presentation is to bring the circle back to the beginning. We were treated during this excellent symposium with exquisite lectures on basic science research and translational research on psychiatric comorbidities and epilepsy. But at the end, we have to come back to the patient, and we have to ask ourselves, how are we going to put together the clinical phenomena that we see in our patient with epilepsy and apply all these different interventions that are being tested for improvement of their seizure disorder and their comorbidities. So I'd like to just leave you with a few concepts. First, for our students, just to remember that epilepsy is not a disorder that consists only of seizures, but is a disorder that also includes in many patients cognitive and psychiatric comorbidities. And these cognitive and psychiatric comorbidities have a very complex relationship, and some of these relationships are a bit confusing, as I'm going to just briefly summarize. Just to remember that psychiatric comorbidities are frequent in people with epilepsy, no matter what psychiatric category you look at compared to the general population, it's going to be more prevalent among people with epilepsy. And I want to leave you with one word that I want you to coin in your hippocampal formation, which you will then transfer to your frontal lobes, and that's a term of psychoplasm. Now, if you look at psychoplasm if you Google psychoplasm in Google, you're not going to find it, because this is a word that I just made up. And basically, I made it up in listening to all the basic scientists who work with cells, and if there is such a thing as cytoplasm, well, there has to be psychoplasm that would encompass the psychiatric and cognitive profile of our patients, and that we really need to keep in mind when trying to plan a treatment strategy and incorporation of the impact of any interventions on these cognitive and psychiatric functions. It's a complex relationship, as we stated before. Not only are people with epilepsy at greater risk of developing psychiatric disorders, but people with psychiatric disorder are at increased risk of developing epilepsy. And just to remember that 1 out of every 3 people with epilepsy will have a lifetime history of depression and or anxiety disorder, or of any psychiatric disorder. And that if we look at the temporal relationship of the onset of psychiatric comorbidities with respect to the onset of the epilepsy, in some patients, the psychiatric comorbidity precedes the onset of epilepsy, and in others, it follows. And in this study of Delhesdorfer, we can see that depression is more frequent in people who go on to develop epilepsy, and you can identify it 3 years before the onset of epilepsy, 2 times more frequently than in the general population. And you identify also that after the onset of epilepsy, some people have 2-fold to 3-fold higher prevalence of depression. But this is true also for anxiety, for suicidality, and for psychosis. So this bidirectional relationship is affecting all psychiatric comorbidities. So that when you see a patient, or when you're doing research that is asking inferences on psychiatric relationship with a given variable, you have to not only conceptualize it as a consequence, but also think, is it possible that the psychiatric comorbidity preceded the onset of the epilepsy? What is the temporal relationship of psychiatric phenomena to seizure occurrence is a predominant question that we have to ask ourselves. And this is just to remember the pleomorphic expression of mood disorders in people with epilepsy. Mood disorders can mimic the primary mood disorders, but they can also have an atypical manifestations, and they very often present with anxiety disorders and very often may have subclinical expression. But it's quite a complicated picture. So it's not enough to just say this patient has depression and give a back depression inventory. We need to be a little bit more detailed on our recognition of the phenomena that our patients with epilepsy have. And by the same token, we have to remember that 30 to 50% of people with epilepsy have an atypical expression where the clinical phenomena does not meet the diagnostic and statistical manual clinical criteria or the DSM criteria. So that if you're working with a psychiatrist in your clinic and your psychiatrist says, well, this patient does not meet DSM-4 criteria for major depressive episode, you're going to, in a very polite way, tell him, well, go back and talk to the patient and establish the psychoplasm of the patient, because that patient is symptomatic and needs treatment, even though he may not meet criteria of according to the DSM categories. Remember that a significant percentage of people with intractable epilepsy suffer from postictal psychiatric symptoms that can last up to 24 hours. And if you imagine that a complex partial seizure or a secondary generalized tonic-clonic seizure lasts about 1 to 2 minutes, but the postictal psychiatric symptoms last 24 hours, well, which is more disabling with respect to the quality of life of these patients. And this is also part of the psychoplasm. Postictal psychiatric symptoms sometimes can be the only manifestations in patients who have an intractable depressive or anxiety disorder, but when they have seizures, the symptoms of depression and anxiety come through. And that's an important recognition that we have to keep in mind. Same thing for postictal symptoms of anxiety. Ictal expressions of psychiatric phenomena are not infrequent. Ictal panic, for example, is one of the most frequent errors that we see in clinical practice, where patients who have simple partial seizures presenting as a panic attack are diagnosed as having a panic disorder. And many of these patients, in fact, it may take up to the point where they have a secondary generalized tonic-clonic seizure before the proper diagnosis is made. Psychotic disorders can have also a variety of expressions, such as mimic a primary schizophrenic disorder, the schizophrenia-like psychosis of epilepsy that was discussed earlier today, postictal psychotic episodes, and the phenomena of alternative psychosis, which is a fascinating phenomena where patients that have intractable epilepsy all of a sudden stop having seizures and they develop de novo psychotic symptomatology. It's not a frequent phenomena, but this is one of the examples of the complexity between the interaction of psychiatric phenomena and epileptic disorders. Several contradictory observations need to be kept in mind. For example, we talked about postictal psychiatric symptoms, where patients will develop, including psychotic episodes. And on the other hand, when we give patients with major depressive disorders, with primary major depressive disorder electroshock therapy, those patients have a resolution of their psychiatric disorder, but also it is a treatment that increases the seizure threshold and can be used to stop intractable status epilepticus in animal models and humans. So this is one of the interesting questions that we get to ponder. How come you're having some patients postictal psychotic episodes or postictal episodes of depression and postictal catatonia, for which which actually follow the occurrence of clusters of secondarily generalized tonic-clonic seizures. And yet, in order to get a patient out of a postictal catatonic state, you have to use ECT, electroshock therapy. So those are fascinating questions that raise some apparent contradiction. Other apparent unexpected contradictory observations are patients who undergo epilepsy surgery for intractable epilepsy. And as you say, as you know, about 50% of people who are evaluated for epilepsy surgery have some kind of psychiatric disorders. Well, some patients will experience a remission of pre-surgical depression and anxiety, and this is seen in 30 to 40% of patients. In some patients, there is an exacerbation of pre-surgical depression and anxiety disorders, 20 to 30%. But in others, there is a de novo development, and this happens in 10 to 50% of patients. And in 3 to 10% of patients, we see a de novo psychotic disorder. So why is it that in some patients we see an improvement of seizures, in others an exacerbation of an improvement of psychiatric disease, in others a de novo development, even though these patients may be seizure-free? This is an example. This is a study of 100 patients who underwent a temporal lobectomy. Pre-surgically, 56 of them had a psychiatric condition, most of them depression and anxiety disorders. After 2 years, 40% had remission of their psychiatric symptoms, and after 8 years, 71%. However, de novo occurrence of psychiatric disorders occurred in 22 patients, of which 4 patients developed de novo psychosis. This is another case series from the largest surgical series in the US that also shows significant improvement after surgery of depression and anxiety disorders. So, if there is one message I want to leave you and that you should go home with is understand the lifetime psychoplasm of the patient. That's it. And Norberto, thank you for a wonderful meeting.